So let's begin. So with the imaging of anatomy of the suprahyoid neck. As radiologists, we discuss and describe the head and neck anatomy in slightly different terms than the anatomists and surgeons do. We describe it in terms of fascia-lined spaces which confine various pathologies. The anatomy is separated by fascial planes into deep compartments, but also by the hyoid bone into the supra- and infrahyoid neck. These divisions are somewhat arbitrary and may overlap, but knowledge is very important. Knowledge of these spaces are very important for better diagnosis, as each space will contain a very distinct group of diseases. We have to have a systematic approach that we use when we are looking at the soft tissue of the neck, whether it's CT or MR or any other modality. First, we have to determine in which space is a particular lesion is located. Then we have to know what is normal contents of this space. And based on these two criteria, we can derive a very good differential diagnosis. So systematic approach is very important. Which space, what are the normal contents of the space, and derive differential diagnosis based on those two criteria. Let's take a look at the anatomy of the aerodigestive tract. The aerodigestive tract here on a sagittal CT, contrast-enhanced CT of the neck, the aerodigestive tract is subdivided into three main components. It is the pharynx, larynx, and hypopharynx. The pharynx contains nasopharynx and oropharynx. The nasopharynx extends from the clivus all the way to the soft tissue, so to the distal portion of the soft palate. The oropharynx extends from the soft palate and into the vallecula. The larynx then extends between the free edge of the epiglottis to the inferior aspect of the cricoid cricoid cartilage. And the hypopharynx is a muscular tube with the posterior lateral margin delineated by the inferior constrictor muscle and the anterior wall delineated by the laryngeal cartilages. The hypopharynx extends from the hyoid bone to the cricoid cartilage. Just a few more words about the larynx. The skeleton of the larynx includes the hyoid bone, epiglottis, thyroid, arytenoid, and cricoid cartilage. When the surgeon performs a total laryngectomy, they will remove all of these contents. Moving on to the coronal cross-section of the larynx. This graphic demonstrates the different subtypes or subsites of the larynx that include the supraglottis, glottis, and infraglottis. The supraglottis is located above the laryngeal ventricle and all the way to the free edge of the epiglottis. The glottis includes the true vocal cords superiorly and extends inferiorly just 1 centimeter inferior to the true vocal cord. And infraglottis extends from that region to the inferior margin of the cricoid. This is an anatomical specimen that also, CT of the anatomic specimen that also demonstrates air-filled laryngeal ventricles with the false vocal cords superiorly and the true vocal cords inferiorly. You also see the thyroid cartilage and the cricoid cartilage along its margins. So there are two major spaces of the neck. It's the suprahyoid and the infrahyoid neck, divided by the hyoid bone. The suprahyoid neck extends from the base of the skull to the hyoid bone, and the infrahyoid neck extends from the hyoid bone to the clavicles. There are multiple spaces in the suprahyoid neck. They include the peripharyngeal, pharyngeal mucosal, masticated, parotid, buccal, and denture spaces. The infrahyoid neck spaces include visceral, anterior, and posterior cervical spaces. And there are also spaces that span both supra and infrahyoid necks, and they are the carotid space, retropharyngeal, and perivertebral spaces. The key to understanding neck spaces is fascia. There are two different fascias in the neck. There's a superficial cervical fascia and there's deep cervical fascia. Deep cervical fascia is what we're going to pay attention to. There are three main layers of deep cervical fascia. There's superficial, middle, and deep layer. And different compartments or different spaces are enveloped or encircled by these fascia. Let's take a look a little closer. The superficial layer of the deep cervical fascia delineates several spaces, and they include the masticator space, parotid, part of the carotid spaces, but also the strap muscles, sternocleidomastoid muscles, and the trapezius muscle. Let's take a look at the level. We are at the level of the nasopharynx on this axial graphic, and you can see that the superficial layer of the deep cervical fascia is yellow. So this fascia delineates the masticator space, the parotid space, part of the carotid sheath, as well as some of the muscles. Here we see this, the trapezius. A little bit lower at the in the infrahyoid space, you see that this fascia, the superficial layer, encapsulates the strap musculature, the sternocleidomastoid muscle, as well as the trapezius. Moving on to the middle layer of the deep cervical fascia, this graphic will demonstrates that this fascia actually envelops pharyngeal mucosal space, visceral space, and the carotid sheath. The pharyngeal space, so this fascia is pink in color. And you can see that it outlines the pharyngeal mucosal space, which is a very important space, and the interior aspect of the carotid sheath. And lower down in the infrahyoid neck, you will see that it outlines the visceral space. The deep layer of deep cervical fascia encapsulates several spaces, including the perivertebral, carotid, retropharyngeal, / danger spaces. So it is in a blue color, and you can see it outlines the perivertebral space, the medial aspect of the carotid sheath, and also the alar fascia, alar and retropharyngeal / danger space fascia. Lower down, you can see that it also outlines the perivertebral space. This is a graphic, an axial graphic of the skull base. And what's important about this image is that it shows the interaction of the four spaces with the skull base. You can see the masticator space, the parotid, carotid, and pharyngeal mucosal spaces. So what's important? This is where the masticator space would be. This is where the parotid space would be. This is the carotid and the pharyngeal mucosal space. You can identify very important structures at the skull base. You will see the foramen ovale and the foramen spinosum. You'll see the carotid canal, as well as the jugular foramen. Just posterior to the styloid, this is the stylomastoid foramen. This is where the cranial nerve 7 would exit. So you would imagine that different pathologies will have access to the skull base through these very important spaces. So let's take a look at the suprahyoid neck spaces one at a time. Pharyngeal mucosal space is a continuous mucosal sheet that extends along the airway side of the aerodigestive tract, and it includes nasopharynx, oropharynx, and hypopharynx. It also includes some minor salivary glands. It is encapsulated primarily by the middle layer of the deep cervical fascia. let's take a look. So where is it? Again, remember this, it's in the middle layer of deep cervical fascia is in pink color, and you can see it outlines the nasopharynx. So what does it contain? It contains very important structures, including the mucosal surface of the pharynx, torus tubaris, which is the cartilaginous extension of the eustachian tube. It also envelops the adenoids, as well as the superior constrictor and levator palatini muscles, all very important structures. Here on the axial CT at the level of the nasopharynx, we see the torus tubaris, the fossa of Rosenmuller, and opening of the eustachian tubes. Moving down to the oropharynx, we can see that the oropharynx actually contains multiple structures. So what are they? Tonsillar pillars, both anterior and posterior tonsillar pillars, the palatine and lingual tonsils, the soft palate, and the superior pharyngeal constrictor. Here you can appreciate the part of the lingual tonsils and a very inferior aspect of the palatine tonsils. We are at the level of the hyoid bone. The hypopharynx has three main components. It is and includes piriform sinuses, posterior pharyngeal wall, and the retrocricoid space. Here on this axial graphic, we can appreciate the piriform sinuses and the posterior pharyngeal mucosal space, and the retrocricoid space is not shown here. On the axial contrast enhanced CT, we can appreciate the air-filled piriform sinuses, and also the posterior hypopharyngeal wall. Another important anatomic structure is another important anatomic structure in the pharyngeal mucosal space is so-called a lymphatic ring or the Waldeyer ring, and it includes adenoids, palatine, and lingual tonsils. Here on a T1, non-contrast T1 MRI of the neck, you can see this iso to hypo-intense structure outlining the airway all the way from the skull base inferiorly. This is the Waldeyer ring. It contains lymphoid tissue. So what are the borders of the pharyngeal mucosal space? Well, let's take a look. The pharyngeal mucosal space is represented here in purple, and you can clearly appreciate that the masticator space and the peripharyngeal space is located just laterally to it. The retropharyngeal space is posterior to it. All very important interactions. Based on knowledge of the anatomic structures within the pharyngeal mucosal space, we can now derive differential diagnosis. So the most common lesion in the pharyngeal mucosal space is the squamous cell carcinoma. Non-Hodgkin's lymphoma may also be seen there, but it's much less rare. I'm sorry, it's much more, it's much less common. There are some minor salivary gland malignancies that are uncommon, and rhabdomyosarcoma may be seen here as well, especially in children. So we just covered the, scratch that. Okay. Moving on to the peripharyngeal space, it contains, so moving on to the peripharyngeal space, it extends from the skull base to the superior cornu of the hyoid bone. It mostly contains fat. There's some minor contributions from the pterygoid venous plexus and the ECA branches, some minor salivary glands, and the inferior alveolar nerve of, I'm sorry. So let's move on to the peripheral space. It's the space that extends from the skull base to the superior cornea of the hyoid bone. It mostly contains fat, with very minor contribution from some vascular structures, minor salivary glands, and the trigeminal nerve. Interestingly enough, all three layers of the deep cervical fascia provide margin to this space. Here on the axial graphic at the level of the nasopharynx, it is outlined in yellow color. So the peripheral space is basically fat filled space in the perimedian neck. It is surrounded by multiple very important spaces. And here on the axial CT of the head, you can see fat density space. This is where the peripheral space is located. On this coronal graphic, we can see that the peripheral space actually extends from the skull base, where it really does not have very many important interactions, to all the way to the inferior margin. Sorry. All right. So this, all right, let's do it. The coronal graphic, this coronal graphic indicates the location of the peripheral space, and it extends from the skull base superiorly to the level of the submandibular space. It empties, so to speak, into the posterior submandibular space along the posterior margin of the mylohyoid muscle. And it is therefore possible for a disease that breaks into the peripheral space to present inferiorly as an angle of mandible mass due to its anatomy. If we look at this peripheral space, seen here as a blue-colored space, it is bordered by multiple very important spaces. Laterally, it is bordered by the masticator space. Medially, there is carotid space, and anteriorly, there is pharyngeal mucosal space. The differential diagnosis for the peripheral lesions is not very long, and it includes lipoma, infection and abscesses, salivary gland tumors, and trigeminal schwannoma. This is an important graph. I'm sorry. This is an important no. The importance of this slide. This slide demonstrates the true importance of the peripheral space to the radiologist. Because of the relationship of the peripheral space to the adjacent spaces, we use the fat within the peripheral space to determine the origin of a lesion. What do I mean by that? Let's say that there is a lesion that comes from the palatine tonsil, for example. So a lesion that comes from a pharyngeal mucosal space, what would happen to the peripheral space? The peripheral space will be displaced posteriorly by this lesion. So we can use this fat and this displacement pattern to determine the origin of the lesion. Let's look at another example. What if the lesion is coming from the masticator space? In this case, The peripheral space will be displaced medially and posteriorly. What if the lesion came from the parotid space? It will displace the peripheral fat anteriorly, anterior-medially. And finally, if the lesion came from the carotid space, the peripheral fat will be displaced laterally and anteriorly. And that is probably the most important part of the peripheral fat in the peripheral space. Thank you very much.